I, as a clinician, need to bash down that false hope type of thing. I want to be positive, I want to be helpful, but I don't want to say, hey, we got a new miracle drug, let's try this out. I need to tell people what the drug specifically is supposed to do in that patient and what are the criteria for which we will increase it, decrease it, stop it, switch to something else. Okay, so we're making a decision as a team. I'm the most informed member of the team about the actual drug, but we need to know what we're looking for together. Otherwise, I'm not going to get good information about what's going on at home. I, as the physician, if I make any diagnosis of dementia, should at least report that to the Ministry of Transportation. That does not result in the automatic revocation of the person's license. It oftentimes does, and I'm allowed to write on a little blank area on the form, and I think this person really shouldn't be driving. But the usual process is that we make the report to the Ministry of Transportation. It burbles through the system. This takes weeks. If you really want someone not to drive, you tell them not to drive right then and there. And when they've got a dementia, and they've got firearms, whether it's in the car or at home, it sets up a whole new set of dangers above and beyond just the fact that you're not demented and you have firearms at home. So we actually ask, when we're in the States, directly, do you have or own any firearms? Sometimes they actually do own them, but they store them somewhere else. In which case, then you need to make sure that the access to those firearms is limited or is through the responsible caregiver spouse. And one of the things that we try to do to protect our families is to make sure that we understand who has power of attorney, and we don't talk to everybody who calls in for information about the patient. We do offer family meetings. We do offer to meet with everybody at the same table. The power of attorney has to give permission for everybody who's attending that meeting. But we try as much as we can to make sure that people feel like they've been incorporated into the team. Because we don't want any one spouse caregiver or one adult child caregiver to feel like they have to do it by themselves. If we can educate the rest of the family so they understand how they can pull together, they may retain some disagreements as to how exactly things are done. But if they can all help with the patient's care, that's actually our goal. And power of attorney designation. Can't be stressed enough how we need to do that early. Especially if it's early enough that the patient can help to make the decision of who that's going to be.
Issues with his behavior toward them that made me feel I needed to protect them from the unpredictability. I could handle it, but I wasn't going to subject them to it. He waved goodbye and gently eased away, and as I looked back at him, his face contorted. And he began to sob, and he cried out loud, "I'm lonely." And I dropped everything and ran back to him and held him, and the kids wrapped their arms around us both. And we just waited there until he stopped sobbing. I'd never seen him cry like that. And then afterwards, when his breathing found a rhythm, I said, you know, we're your family, and we'll always be here for you, and we love you no matter what. And then he kind of wiped his face and said, well, I'm going for a run now. I had gotten used to the shifting terrain, and it didn't surprise me. So I said, well, that's great, you go do that. And as the children and I finally eased away, we made sure he was okay. He walked off and prepared for his run. We walked away, Chris said to me, that was so sad. I felt so sorry for him. And I said, well, I'm really proud of you two, because now you know what it feels like to forgive someone completely. And Allison said, yeah, because he's sick. And I said, no, because he's a human being. And we all need to be forgiven at one time or another.
They had not been spending much time together in the previous months. She was trying to protect them from all the strange behavior and the difficulty of the divorce proceedings. And so they were exchanging Christmas presents in the park. A very difficult, ambiguous, emotional situation, right? You're so glad to see these people that you're so dedicated to, that you haven't seen in a long time. You're exchanging gifts, but it's so terribly, tragically sad too, because he understood at a certain level that he'd made a decision to walk away from that, and now the time had come for him to do exactly that. We say that in the diagnostic criteria for frontotemporal dementia that there's an emotional blunting. And oftentimes you'll see that in the patients, and that they have this sort of robotic stare or a glazy, expressionless face. However, they do not lack emotions. They can react emotionally to somebody's face, harsh words, or they can get into a cold sweat if they're very nervous. Problem is that they can't accurately recognize what that emotional content is. So you see a face that's not just a smiling face. The patient can't tell whether that's disgust or surprise or sadness or anger. So it can be very difficult for them to respond appropriately. And when it's an ambiguous situation, such as what Katherine described in the park, they might go through a range of different reactions to that, as Ed did. Different from Alzheimer's disease. We've got younger patients. They're not in their 70s or 80s. Their children are not grown up with children of their own. They have some kids who are still pretty young. In fact, one of my patients with corticobasal syndrome has four sons. I might be forgetting the exact details, but the youngest of the sons is 10 years old. The oldest one is just getting ready to leave high school. That 10-year-old is the member of the family who spends the most time with his dad. Who's supervising this man to make sure he doesn't wander out down the street during the day, and keeping him entertained, and making a little snack for him in the microwave? It's that 10-year-old boy.
When we come into your office or talk to you on the phone about our marriage, we are not talking about our marital problems with you. You have not become the family counselor. We are trying to convey to you, with the most powerful evidence that we have, that the person we are living with is completely different, is someone we don't know anymore, and has, in many instances, lost most of his moral structure.
One of the things that we don't talk to caregiver spouses about spontaneously, I did not bring this up, but I probably should, or I should talk with my nurse, Mindy, about how we can infuse this into conversations with when we have just the family member in the room. Sex. Not a dirty word. The intimate life that two people share is so important to them. And in many cases, even though we don't think about it, maybe because we don't want to, these people are still having a sexual relationship, despite the fact that there's all this odd behavior and whatnot, because it can be a source of comfort to both of them. There are times at which the sexual behaviors can actually be more compulsive, obsessive-compulsive, than an act of intimacy. Does that matter so much if both people are getting something good out of it? It's up to you to decide yourself, but we need to provide counseling about this. If the patient is disinhibited and is able to wander free during the day while the spouse is at work, there is a possibility that this person is getting into bed with other people outside of the marriage who may bring risk of sexually transmitted diseases into the home. Now, it may be a long time since the spouse had to even think about what does a sexually transmitted disease look like? How do I detect whether there is one? These are the important bits of information that we need to arm our caregivers with so that they can protect their own health and hopefully that of the patient. But there are certain things that we have control over and other things that we don't, despite our best efforts.